Good evening, everyone. It is 7 p.m. now. It is April the 16th of 2020. We are in the National Palace of Mexico in Mexico City. And let's begin with our daily conference regarding the world and national situation regarding COVID, the disease caused by the new coronavirus SARS-CoV-2. Today we'll be talking about four topics. First of all is the daily technical report. Then we'll have the weekly estimations of the epidemiological vigilance model, the sentinel model. And we have a very special guest that has been here before, Dr. Jose Ignacio Santos Preciado, Secretary of the General Council for Health. He's a wide-renowned national and international researcher and professor. Also, we have Dr. Ricardo Cortes Alcalá. He's the creator of the Susana Distancia character for the keeping of safe distance. And he will be presenting a report regarding the mobility rates and the impact that the mitigation measures have had in regards to mobility in the public space. Because by staying home and reducing our mobility in the public space, we can mitigate the effects of the pandemic. And we'll be looking at a report of whether we've seen this decrease or not, and the per state distribution. Dr. Alomia, please, can you begin? Thank you, Deputy Secretary. Good evening, everyone. Let's begin with the international scenario. As you can see, the statistic that we have in the middle is the one that we've been observing closely for a few days, which is we are seeing a downward trend in the overall active representation of the pandemic. It went from 57% yesterday to now 55%, which means we are near to the point in which only half of the cases that have been reported so far worldwide have manifested themselves during the past 14 days. Talking about the fatality rate, we have an average 6.6 fatality rate globally. And we take a look at the next slide. There was no significant variation in these proportions. They are pretty similar than the ones we saw yesterday, but we can see that the Americas is right there with the European region when it comes to representation of the pandemic worldwide, and will probably continue to increase during the upcoming days, since the Americas entered the pandemic later than the European region, and now the European region is fortunately but slowly coming out of it. So the burden of disease for the past 14 days in the Americas is over 40%. Here we have the national landscape. To this day we have 6,297 cases confirmed by laboratory testing. We have 12,340 suspect cases. We have 26,511 negative cases, and unfortunately the death toll is now 486. In total we have studied over 45,000 cases, and we can see how the distribution of the infected cases is represented on the map per state. Darker red being the higher concentration ones, lighter green being the lower concentration ones. The higher concentration states have over 1,000 cases each. Here we have the same distribution but presented in the form of a bar graph. Here you can take a look at the complete data of each state. This is, remember, we're talking about the number of confirmed cases per state. Next slide, we have the national map, but now we're taking a look at the accumulated incidence rate. which is a comparison that takes into account the population within each state, and the darker green states are the ones that have a higher accumulated incidence rate as compared to their populations. So of course the representation of this map is different than the first map, and this is actually a better way to compare how great is this impact being in each of these states. And we can see how during the past 7 days we have observed that the same states remain to be the ones overrepresented in this scenario. Here we have the same information presented in the way of a bar graph, and you can quickly identify which states are the ones that have a higher accumulated incidence rate, and the national average is 4.92. Here we can look at a map that will be presenting every day since today. This morning we presented this map, and this is the distribution not only per state but per municipality in those municipalities that have reported cases, and it goes from one case to more cases, and depending on the number of cases, the municipality appears represented in a specific shade of green. We have 483 municipalities, which is 20% of the overall amount of municipalities in the country, that have presented at least one or more confirmed cases. So as you can see, the specific measures that we will be continue to adopt, and the new ones that we'll be adopting, are based on this per municipality distribution. This map will be updated every day based on the newest information that we are presented with. So starting from now until May the 17th, which is the first date that we have planned so far for lifting some of the restrictions in some of the municipalities, we'll be monitoring this whole situation and presenting it through this map. Here we have our per age group distribution, but also we are looking at the proportion between inpatients and outpatients between per age group. So as you know, the inpatients are the ones who had to be hospitalized at some point because of the severity of their symptoms, while outpatients represented in green are ones that exhibited mild symptoms and did not need to go into the hospital. Obviously, we can see that the older the person is, the more likely they are to be in the need of requiring medical attention in a hospital. We also have the gender distribution. Males continue to be overrepresented in the number of infected cases by a similar percentage that the one we have been observing during the past weeks. Here we have, out of the population that has been hospitalized at some point, what was their clinical status at the moment of being hospitalized. So 64% were outpatients. This means they just went into the hospital to get tested. Then we had 11% that were stable, hospitalized but stable. Then we have 20% that were in severe condition, and 4.5% had to be intubated, unfortunately, and this is the most critical presentation of the disease of COVID-19. And remember, this data is the distribution of the confirmed cases, of these over 6,000 cases that have been confirmed through laboratory testing. However, in the next slide, we can see how we have also the data of those people who remain suspect cases, which means they are awaiting for the results of their tests, which are represented on the first column. And we have the same distribution So out of these people who are still waiting for their results, what is the distribution regarding their status? So of their clinical status, but we also have the same proportion for the fatalities so far that are awaiting for confirmation, because some of the fatalities that have been reported already haven't been confirmed to be related to COVID-19 yet, so we are still waiting for the test results to come out. So far we have 486 deaths that are confirmed to be COVID-19 and another amount that are awaiting for the results. Here we have the representation of the deaths per the date in which they unfortunately died, in which the patients died. We have two kinds of information here: the accumulated death toll, which is the line in black, and then we have on the bars, we have the amount of fatalities that have occurred per day. We have the data from the beginning the epidemic started, and then after April the 7th, we had a more stable trend. Remember, the last two bars are not that representative of reality, because some of those deaths are still waiting for confirmation, but the other graphs are representative of the overall trend that we have been observing regarding fatalities. Now here we can take a look at the death toll, and take a look at the death toll related comorbidity factors, meaning which are those conditions that are most highly associated with the probability of dying because of COVID-19. Of course, the leading three continue to be hypertension, diabetes, and obesity, but we also have other conditions that elevate the risk of dying from COVID-19, such as smoking, kidney failure, immunosuppression, and others that appear here. We are still studying some of these elements and how they associate to a higher risk of death. Men are still overrepresented. They represent over 70% of the fatalities overall. Here we have another representation of the fatalities per age group: under 25, 25 to 59, and after 60. And here we have two kinds of data that we can compare. One of them is the fatality rate per age group, and the other one is the mortality, which is the total number of fatalities. So as we can see, the fatality rate is higher for older people. For the over 60-year-old age group, they have a higher fatality rate, even though they have a lower mortality number. Here again, we have the fatality rate distribution per state that goes from 23.53, and the lowest would be 2.82, and there is variation depending on each state and each specific circumstances. Remember, this is the amount of deaths per 100. This is the amount of deaths related to the amount of confirmed cases. Here we have the positivity rate, which is out of those tested patients, which of them came out positive for COVID-19 and which of them were not positive, and they were probably positive for other viral infections that were also similar to COVID-19. So the current positivity rate is, as you can see, 16.45, and as the COVID-19 positivity goes up, remember the data for week 16 is the one that week 16 is the week that is currently happening. So this final number will show some variation by the end of the week, but so far it is 16.45. So that is a trend. And what we haven't seen anymore for the past 5 weeks is an important prevalence of influenza. So the blue line is the positivity rate for influenza, which has practically disappeared in accordance to the hotter weather that we are experiencing in Mexico right now. Here we have the information for the recovered cases, a total of 2,451 that account for 39% of the overall confirmed cases. Here we have the accumulated curve for the suspect cases, and this is presented taking as reference the date when the symptoms started, right? So these dates that appear represented are the dates where the patient started exhibiting symptoms. Remember, the symptoms that happen with COVID-19 are similar to those of a flu or of other viral infections: headache, coughing, red eyes, exactly, etc. And then if patients exhibit these symptoms, they notify the medical consultation platform, and then they are oriented as to whether they should get tested or not. And after they get tested, then we have confirmation of whether they have coronavirus SARS-2 or other viral infections. This is when they exhibit severe or moderate symptoms. In the case of the mild symptom patients, they are just recommended the proper care measures. They isolate themselves at home, and there is only a 10% of the mild cases that are tested for statistical analysis. Here we can observe this new slide. We have a variation of 3% during the past 3 days, but we still need waiting for the data to stabilize. So we need to wait a little bit to see if this curve will continue to go up or will flatten a little bit. And this is the last slide, which is the accumulated epidemic curve, with the line representing the accumulated amount of total confirmed cases, being the current one 6,297, and then the little orange bars represent the newly confirmed cases per day. And we can also see whether there is an upward trend or not here, and we are monitoring for that. So as you can see, on April the 8th or 9, the upward trend that we had been observing regarding newly confirmed cases every day started to flatten, started to stabilize a little bit, and we are continuing to monitor it. Thank you. That would be all for my technical report. All right, now I will be presenting the weekly estimation of cases that is derived from the sentinel model of epidemiological vigilance. Here I would like to present a map which is on the same presentation. Let's see. The 475 units that are used to monitor respiratory diseases that were previously known as monitors for influenza. Now they are expanded their capabilities to monitor for respiratory diseases in general. We have these units represented in the map, so you can have a visual image of their location. And you can see how these medical monitoring units are strategically located throughout all the country to cover the totality of the national territory. Now, through this system, we can have this is a representation of the different states of Mexico, but also of the different levels of complexity of our national health system. We have health centers, we have familiar medicine units, we have mobile units, we have general hospitals, and we also have specialized clinics and hospitals. For example, the National Institute for Respiratory Infectious Diseases is a specialized unit. And the second set of data that we show here is the different organizations, different categories that our medical units nationwide belong to: private industry, public sector, universities, IMSS, ISTE, the Navy, the Army, different institutions, right? So this is a representation, a very wide representation of the institutional diversity that we have when it comes to our medical units nationwide. This is now the same chart that I showed you last week, meaning it is the same logic, and let me explain and go into further detail about what we explained 7 days ago. First column, we have the weeks, the epidemiological weeks. They continue to go up. Right now we are at week 16, and we're presenting information all the way to week 14. We have a 2-week delay because the incubation cycle of respiratory diseases in general has weekly processing of information. So that means that every 2 weeks we have a complete block of information of all of these different diseases in over 26,000 medical units all over the country that integrate the national health system. We have 3 clinical symptoms that we focus on. We have acute respiratory infections, we have pneumonias, and we have influenza. And this is what we register per week. At the end, we have the total. Second column, we see out of this set of people who went seeking for consultation, which ones met the requirements to be determined to be infected with influenza, but technically with influenza because or influenza type disease. And we've said that COVID-19, from its technical side, from its technical aspect, it is indistinguishable from influenza. So we consider it as an influenza type disease. So it enters into the influenza type disease account. And it's important to remember that this information is presented in relation to the total of consultations that are given out from the medical units throughout the country. Let's see the other information here. We have the samples that are gathered in different medical units for the diagnosis of different viruses. Remember, we have the infrastructure and the system to diagnose 14 different viruses, including coronavirus SARS-CoV-2. Out of these tests that are carried out, there is a number that turns out to be positive. Remember, the first weeks we didn't have any positive tests, even though we were monitoring it. We were taking these samples, we were carrying out these tests, but the first weeks in Mexico of the global pandemic, we didn't have any confirmed cases, and that is how we knew that we didn't have any case in Mexico before February 28th, which was the first case. Now this gives us a percentage, which is the percentage of the percentage of positive results out of tests that were done to patients in the monitoring units. Finally, we have the data that corresponds to the weekly reports and notifications from each of these monitoring units regarding their overall number of cases of pneumonia, influenza, or acute respiratory disease. But in this case, we do not test in all of those units. We only test in the 475 monitoring units. So we wanted to expand all of those cases that if they had been tested, they would have been tested positive for both the acute respiratory syndrome, diagnosis, and also because of the laboratory testing of COVID-19. And these are the resulting numbers. And finally, we have the estimated number of COVID in the 26,000 units. Basically, the cases that we do not get to see because they are not in the monitoring units of disease. We've also said that the severe cases and the hospitalized cases and all the people who unfortunately lose their lives are registered 100%. So the estimated number is for the outpatients, is for the mild symptom cases, not for the severe cases. If you're interested in how this mathematical model works, feel free to do the calculations to make sure that the data actually matches what we are presenting right now. And this is all written in the technical manual of epidemiological vigilance of influenza. And this is not presented here because it's a little bit more complex and more technical. So this is the national aggregate, but here we're not presenting the categories of age group and state. This in epidemiology, this is called age group standardization and geographical region standardization. This is not here in this data, but this is written in the manual. So you have to take that data into account if you're going to do the manual calculation. Now, finally, out of all of this, we have an accumulated estimated cases overall since week 1 of 55,000 people who we estimate have had COVID in Mexico, and that correspond to the sentinel model of epidemiological vigilance. Finally, this is an important element. This is the same chart that was just presented regarding the fatality rate in confirmed cases, in directly observed and confirmed cases. We've been saying since the process of the sentinel model and started functioning, that exists in Mexico since many years ago because of the influenza pandemic of 2009. We've been saying that because of the use of this model, there is an overestimation in the fatality rate. And because the fatality rate is an indicator for how aggressive, how severe is this disease overall, this could be confusing. In the whole world, we have a fatality of over 6%, barely over 6%, and here we have an overall fatality of 7.72. Well, each country has its own method of epidemiological vigilance. We in Mexico explicitly identify those cases that are not observable through mathematical and statistical analysis and estimation, but other countries do not do this. So of course there will be a discrepancy in the overall rates. So we want to present a new index, which is the fatality in estimated cases. Fatality in estimated cases. Now take a look at how it is notoriously smaller, but it's clearly identified. So this is the upper one is the fatality in confirmed cases, and this is the lower one is the fatality in estimated cases. This is a more reliable indicator of what happens overall with the epidemic in our country, considering that a lot of people that had been infected with COVID had stayed at home, and they have stayed at home because it is a public interest that these people, that all of us, but especially these people who exhibit mild symptoms, for them to stay at home, because in this way we can avoid saturating the clinics and the hospitals in our country. But of course we are providing continuous monitoring and vigilance of these cases. Now, okay, doctor, now you have the floor. Can we continue with the topic you were talking about this morning, and it was somewhat inconclusive? Yes, thank you very much, and thanks for the opportunity to present the overview of what are the reasons for the guidelines that were published in the website of the General Health Council about a week ago. I'll be brief in my presentation. I'll talk about the purposes, the nature of the guidelines, the processes that ought to be followed to implement them, as well as some information regarding the equipments. Since March the 19th, when the General Health Council called for the beginning of the hospital reconversion program, because as you know, the General Health Council is not sectorized. So we are working in close collaboration with both the private sector and the public sector. And we have announced a few weeks ago that there is an alliance plan in which two of the biggest associations of private hospitals are supporting this federal government initiative by providing over 3,000 available beds in their hospitals. All right, now the process for decision making in this emergency is that of when we have an emergency of this nature that can potentially overload the availability in our medical institutions, then we have to organize the response in these situations. And this response, in this case, this response to this virus, SARS-CoV-2, this response is aimed at guaranteeing objective, scientific, and bioethic criteria for the selection of patients in the presence of scarce resources. So its aim is to eliminate any way of favoritism or corrupt practices or unfair practices. And it means to liberate the medical practitioners from the psychological burden or of the execution of an inevitable act, which is the decision between two infected patients regarding which of them should get the priority medical attention. The nature of this set of guidelines is that it is basically an instructive. It is a manual for the medical professionals to be able to solve dilemmas. Basically, it is a set of guidelines for the scientific, legal, and bioethical administration of human and material resources. Because this set of guidelines cannot be implemented only through legal concerns, we also have had the collaboration of philosophers, psychologists, doctors, lawyers, gene researchers, and other professionals from other fields of expertise. This guide does not exclusively consist in bioethical principles. It also has technical aspects that go from the correct treatment of emergency cases to the psychological handling of specific situations. And it has been approved by the General Health Council. Now, first there was a file denominated Guide Project for the attention of emergency situations amidst the COVID-19 health emergency, and this document was uploaded to the General Health Council's official site and the Ministry of the Interior official guide. This was uploaded in the with the status of being a live, not definite document, in which we had a period for adjustment, and that we invited the feedback and the collaboration of all members sectors of society for the betterment of these guides, and now we have finally concluded them. Now, this, after the proper approbation procedures, this final document will be presented through the Federal Official Gazette. Now, the guidelines contemplate the existence of a team that has a hierarchy of doctors, nurses, and specialists that will be operating the decision-making processes. Now, the official personnel in charge of this process will have the following functions. They will have to supervise the overall process of decision making. They will also personally observe each emergency case in their specific situation, and they will gather all the information through a list and communicate to the relevant hospital authorities and doctors. They will also update the priority list in a continuous manner and notify all the relevant administrative sectors of said clinic. Finally, this decision-making team will inform the patient and the patient's relative, which is very important to have communication with the patient's relative. They will inform the result of this very complex and specialized decision-making process. So, in conclusion, this guide will be used only when there are not enough resources for the proper and timely attention for all patients, right? So let's contribute to the avoidance of the overwork and overload of our medical system by staying at home. Now, but let's remember that it's not the criteria that are included in this decision-making process are not simple. It's not a matter of pre-existing conditions alone, just not the fact of having diabetes, obesity, hypertension, or belonging to a certain age group is not the only factor that will be taken into account. The principles that we observe are the universal principles of justice, of ensuring of well-being, but also there are some certain principles that are not explicit, which is the duty to care, the duty to administer, the value of transparency, the value of responsibility. And as you know, this document that we are talking about has the objective of saving lives. Resources will be scarce at some point because we have seen this in all of the countries that have been suffering this pandemic. So to not prepare for this situation would be to fail ethically to all of our patients. Thank you very much. Finally, Dr. Ricardo Cortés Alcalá, can you share with us the information you have prepared regarding mobility in the public space? Thank you, Deputy Secretary. Let's begin with the presentation. Here we can take a look at the report, a mobility report per state. This is important. This is a community mobility report provided by Google, which is a service that they provide as an auxiliary service to observe what has been the decrease or increase of mobility in public spaces, monitored by the use of our cell phones. When you authorized an app in your cell phone to know your location and follow you, then you're giving your explicit authorization to these companies to register your location and your transportation routes, and this allows us to have these tools for analysis. Thank you to Google for this. Also, Apple has provided some data, and other companies as well. Here we have the mobility in regards to purchases and entertainment. We have a negative scale nationwide. We have reduced our mobility by over 60%. Baja California Sur is the state that has reduced in the greater extent, and the one that has done it in the least is still near 60%, which is the state of Hidalgo. Now, this is mobility regarding transportation stations. We also have a geographic reference of these transportation stations, and we can see how the mobility has increased or decreased. Nationally, we're also dealing with an average of 60% of reduction, of decrease of these mobility rates in public transportation, with almost 90% of reduction in Quintana Roo, and about 40 something percent of decrease in the state of Querétaro. The state of Querétaro, that is the one that shows the lesser increase according to this data, also has a reduction of over 50%, well, almost 50%. So, good news. Now, let's look at the mobility in the workplace data. Nationwide, we have seen a reduction of 50% average. Baja California Sur is the state with the highest reduction, which is 60%, and the state of Veracruz has almost 40%. We have to go into deeper analysis on this set of data because the work activities, the government has emphasized and has expressed that it is a necessity to suspend the non-essential economic activities, and this can give us a global vision, state vision, and a nationwide vision of how these decreases have occurred in the workplace. And last slide, this is stay at home. The residential mobility. This is not a negative number, this is a positive number. It is good that is a high number, a high positive number. Nationwide, we have been 20% more at home on average that we were on the first days of January. Quintana Roo is the state that has had the highest rate, almost 30% staying at home more than before, and Tlaxcala has been staying at home almost 20% more than before. That is the range. This is also very important to analyze because let's remember the reasons. This monitoring happens as long as you have your cell phone activated, or your cell phone is powered on. So that also affects a little bit the registration of information. But let's not lose the opportunity to say that if this is an accurate reflection of the stay-at-home policy effects so far, we need to stay at home more. So stay at home. Stay at home. All right, let's begin with the Q&A period. Thank you, Doctor. I'm Bianca Aguirre from Notimex. This morning you announced that the first cycle of the pandemic would end on June the 25th. What does this mean? What is the first cycle? Does this mean we're going to be seeing other cycles, and what are they going to be like? Yes, this morning I wished you had asked this question. Nobody did, and I didn't have an opportunity to clarify. So it's good that you asked this now. Infectious disease epidemics do not exhibit a unique behavior. As we have been showing in the municipality maps, it is not happening, the epidemic is not happening at the same time on each of the 129 million people that live in Mexico, but they show specific trends by geographical location. So the result of this, the consequence of this phenomenon, is that it is possible to have an asynchrony, a discrepancy in time, a very important discrepancy between the first locality that was affected and the last locality that was affected. To the extent that we have people who are still susceptible to the infection, meaning that they are not immune, it can happen that this first epidemic outbreak or this first epidemic curve could end in a locality, and then a few weeks or months after that, there could be another outbreak in the same locality coming from a different origin, from a different locality. For example, Mexico City was the same locality in which we had COVID. This is where the first case of COVID was registered on February the 28th. But once we get over all of these weeks and the transmission rates go down, it could happen that when we lift the restrictions of mobility, there could be a reintroduction of the infection coming from other location that has still active transmission, or even from another country. So to the extent that this is a worldwide phenomenon, and that is why it's called pandemic, because it is in the whole world, there is also an important asynchrony, an important time discrepancy between regions and between countries. Just for you to get an idea of the sort of consequences that we could be seeing, let's talk about the experience we had 10 years ago with the pandemic H1N1 influenza. The pandemic started in April and it lasted all the way through May. Then the first cycle was over. There was not a lot of transmission. In June we have a tiny outbreak, in particular in Chiapas, in the southern part of Mexico. Then we didn't have any important transmission. And then when we entered October, November, December, and January of 2010, we had again a bigger outbreak than the original outbreak. And the explanation for the case of influenza was that the hemispheres of the world have an asynchrony when it comes to the seasons. So when we are having winter here, over there they're having summer. When we are having autumn here, over there is the spring, and vice versa. So the infection traveled to the southern hemisphere and then it came back. So there were 3 years that went by between this whole process. So for the new coronavirus, we still don't know if this phenomenon could occur, but we shouldn't discard it quite yet, because there are similarities in other regards with influenza. Thank you. Hi, I'm Jocelina Redondo from Notimex. This morning, you talked about some measures relating the mobility. Can you elaborate? Also, the Michoacan governor today, he said he's not going to listen to the measures of the federal government. Does he have the authority to say those things? Yes. The question you asked, it is related to the first question that Bianca asked. That is why we determined as a new measure the segmentation of the regions. The scientific consultation groups, when they identified this asynchrony and this unequal distribution of the intensity of the epidemic within the different municipalities, they recommended using another of the components of the overall strategy, which is the local contention regarding the mobility in the country. So the segmentation in mobility, what it means is we're going to take a number of municipalities, for example, the green area of the map that we observed, so the municipalities that have very little transmission or no cases at all, and they will be considered a risk area, and we will instrumentalize the mechanisms for people to only be mobilizing within those areas. If they had to leave those areas for some justified reason, then they would have to go through additional filtering mechanisms so we can control this epidemic. This was a proposal from the scientific consultation groups after analyzing the data and the mathematical models, but this is not a new measure. This is a measure that has been used for decades, maybe for centuries, for the control of epidemics of different nature. Thank you. And will there be vigilance for ensuring that the people respect these segmentation strategies? We are still considering it, and this will be subject to the judgment of the General Health Council. And talking about the governor of Michoacan, well, the fourth health authority, according to the fourth article of the General Law of Health, are the state governors. So each governor has a certain competence area as it is defined in the law. And then there is also an area of concurrency, which means there is a shared responsibility. So what we can say is the three health authorities that are the President, the General Health Council, and the Secretary of Health, they implement and announce general dispositions, and the state governors are responsible for their specific territories. Thank you. Thank you for the opportunity. I'll be brief. You have clarified that the bioethic guidelines started as a project and now it has evolved and is a live document. I want to say that it seems like it relies on a biopolitical concept, and I want to know if you are considering to include other specialists into these considerations. Also, when is this set of guidelines going to be officially presented, and how is it going to be ensured that it is effectively applied in hospitals? Are there going to be any law enforcement mechanisms to make sure of this? Also, second question, are you in conversation with the provost of the National Autonomous University, because he complained about the guidelines? I think that was a matter of misunderstanding, because this was not a General Health Council calling. This was a specific work group that was authorized last week, but it was not a General Health Council project. And getting back to the first question, this document is nothing new. All countries that have had to implement and design general guidelines that are similar to these ones, they have done it in a similar manner. And here, what we are proposing as a council, as a general council, we are proposing to have this prepared beforehand. We are not anticipating a catastrophe. We are proposing to have this in case we need to make use of it, because resources are scarce all over the world, and we've seen it and we've lived it in other countries. So the idea is that this project has the precepts that are ethical, bioethical, and according to the law, of course. This has to be approved by the council and then published on the Federal Official Gazette, and then it would be implemented. Now, because remember, for the council to certify a hospital, one of the requirements is that the hospital has an ethics committee. So once we publish this in the Federal Official Gazette, it will be socialized and presented to all of the health workers. And the idea is that all of the state, well, this is a set of guidelines, and because of it, it can be interpreted, but the objective is the same: to save lives, to utilize the resources in a rational manner, and to recognize that there are people who are at a higher risk of being susceptible and of presenting complications, and to insist that all of us stay at home. This is part of the focus of this set of guidelines. And why do we find its origins in the council? Because it is an attribution, it is a duty of the council to see that we are protecting the health and the security of all the citizens. Thank you. We have 2 minutes left. You were talking something about state governors and the governor of Michoacan. And I think we have a video that clarifies part of the elements that you were talking about. Do we have a video? All right. It's not ready, so we'll play it tomorrow morning. All right, next question. We have 2 minutes left. Thank you, Ernesto Ledesma from Rompeviento. Dr. Lopez Gatel, with respect to the people who are more susceptible, who are at a higher risk, like hypertense patients, diabetic patients, my question is related to malnourishment, to malnutrition. Is this also a risk factor? And I'm asking this specifically because of our indigenous peoples. In the state of Chiapas, we have documented that there are over 9,000 originary people or originary people members that have been displaced from their hometowns, and they are in complete abandonment. And I don't know if they are in a more vulnerable situation in the face of this pandemic. And are you having some specific measures that address them? Because in Chiapas, they have not had any help from the government, specifically because to them, if you tell those marginalized communities stay at home, they will reply, which home? We don't have a home. And also, my second question regarding all this pandemic, so to speak, of fake news that has been launched by a lot of media. But talking about these videos that have been viral of hospitals and clinics in which they show chaotic conditions of operation, I want to ask, is the Ministry of Health preparing clinics and hospitals regarding logistics and giving them a logistics protocol in order to have more orderly operations? Thank you very much. They are extraordinarily relevant questions. Yes, indeed, it wouldn't be rare, and I'm using this term because I do not know rigorously enough definition of malnourishment and the risk of complications in COVID, but by analogy with any other infectious disease, I would say yes, malnourishment is a risk factor. And this malnourishment can be because of a massive insufficiency of either food or either nutrients. This could derive into a malfunctioning of the immune system, and of course a higher risk if infected with COVID-19. The epidemic was traveling, so to speak, before we have in China, then extended to Europe and to the US, and now it is a turn for a lot of countries that we are amongst those countries that have a lot of people who have lived in chronic conditions of poverty and of insufficiency. We've said it over and over again that it is outrageous that in Mexico we have near half of the population living in poverty. This is a great injustice. So what to do about it? Yes, I know there are displaced people who do not have a home. Of course, the concept of stay at home is a generic call for the majority of people, but we know there are people who live in very adverse conditions displaced people, migrants, or homeless people. They don't have a home either. What can we do? What we can do, and we have been doing, is to rely on the several social programs that the government has. The support networks, because we have a lot of support networks, they are now putting all of their attention on the COVID pandemic. We talked about this before, and it would be a privilege to be able to have the Secretary of Well-being, that is the one that coordinates all these different social programs, and all of these colleagues that operate and coordinate this apparatus of the federal government. It would be great to invite them here so they could talk into further detail about these programs. But these programs do exist, and they are helping to mitigate the impact of the epidemic on people. Thank you. We have the video, I think. Now, regarding the chaotic conditions in hospitals, is there any logistics protocol? Yes, thank you. This triage protocol that and process that the doctor was talking about, the general concept of triage implies the identification of priorities. The situations that you are relating is that we are having visual images of the access points to hospitals in which we can have great influx of people who are searching for medical attention. And the most probable thing is that a high proportion of these people have mild symptoms, but some of them might have moderate symptoms, and a few of them may have severe symptoms. So something that we cannot have is that they are provided treatment in the order they appear, because the priority is for the people who have more severe symptoms. So the protocol for the hospital reconversion that we published last week and that we've been working with when providing consultation for the state governors includes a segment on triage and of the correct logistic operation of these situations. So thank you for the question. One last question and then we'll show the video. What happens before? I want to know. Because you were talking about the guidelines and the project. So they're similar, right? But does this mean they're going to be, the project has to be subjected to approval? What happens first? There is a discussion between all of the members of the council and then it is approved. Could it be modified based on the opinion of the members, or are they informed of it once it is published? The General Health Council has 13 members that have voice and vote. Recently, we had 3 new members that are gonna be helpful specifically for the valorization of the contingency we're currently experiencing. This process is subject to the acting members that have voice and vote and to the extra members that are only observing. And it is subject to their consideration or their approval. So that would be the sequence of the guide. The guide, it is solid. It has solid legal basis, solid ethical basis. All of the people who contributed to its design are experts in their fields. One of a good proportion of them are from our National Autonomous University. Some others are from other international institutions, such as Oxford University, for example, and the guidelines have all the necessary elements. Alright, let's show the video. This is about Michoacán and the question that you were posing regarding the process of repairment of ventilators in the Michoacán area. The Mexico National Technological Institution, the Morelia campus, in collaboration with other institutions, including IMSS, they are collaborating with the diagnosis and the eventual repairment of a set number of ventilators. So IMSS transports the equipment from Mexico City to the city of Morelia to begin technical examination. Then the personnel at Morelia counts and disinfects the ventilators using the proper chemical solutions that were developed by biochemistry specialists of our university. We use a dosifier to sprinkle the liquid, and then we clean and disinfect these ventilators. After that, they are cataloged per brand to be subject to an initial evaluation. The researchers test the ventilators to test their functionality, electronic and mechanical functionality. During this process, we pick out the equipments that are suitable for repairment. So they are repaired, and then towards through a specific software, simulations are run to make sure that they are functioning correctly, and after that they are given back to IMSS. This, of course, is done with the help of professors, researchers, and students from different universities and institutions, as well as full-time workers and specialists of other medical institutions. In this way, the National Technological Institute of Mexico contributes to the mission of preserving the well-being of the overall Mexican society using its best elements and knowledge base on a national and international level. Well, I think it is very clear. It is the National Technological Institute of Morelia. Obviously, it is in the state of Michoacan. I think it has to do with what you were saying. I would like to say the following, talking about the health authorities. State governors and governments are health authorities as much as national health authorities are health authorities. The law is very clear when it comes to the process of collaboration and shared responsibility in this regard. We are in the face of a historic process in which the national system, not only the health system, but the overall national system, is undergoing a certain amount of stress. And this, because we are all human, could sometimes derives in the necessity of expressing what oneself in a way that can be confusing for the citizens, especially because the citizens are looking to find calmness and to find reasonable decisions and sensible decisions in us. But I think these kind of declarations and expressions of feelings are natural, are normal. We'll still have at least 6 weeks of joint effort, and I think we should all remain calm, sensible, kind to each other, and identify that we are all one country. Everything we do is going to have a positive repercussion on all of us if we keep a positive attitude. I think that's the best thing we can do. Thank you very much. We're out of time. We'll continue tomorrow.